So here, when the U wave is attached to the T wave, you use the nadir between the T and the U waves. So here's the T wave, here's the U wave, and there's a little dip between those two things, and you use the nadir of that to determine what the QT interval is. Because it comes up a fair bit, you can see here where there's a U wave and it's attached to the T wave, and it's kind of hard to tell where the U wave starts, where the T wave ends, but that's generally how I do it. And here's, you can take a look at this one here. T wave, U wave, nadir. This would be the QT interval here. So in this example, as we discussed in level 2, that was 480 milliseconds. The next one's here. The Bazet QTC formula does not accurately predict risk at higher heart rates, so around 100 beats per minute or more. It just doesn't work. And then the last item here is short QT, which doesn't come up as much as long QT, is defined as less than 330 milliseconds for heart rates in the 60 to 100 range. And things that cause that are hypercalcemia and hyperkalemia. On to arrhythmogenic right ventricular cardiomyopathy, which is a pretty unusual condition that affects the right ventricle and causes some conduction abnormalities. The hallmark is here, the epsilon wave. And that's a little notch basically at the end of the QRS. So you've got the QRS, and then this right here is the epsilon wave. And you can see that in any lead. Another feature is T-wave inversions in leads V1 and V2, V3, which is very common anyway, so isn't particularly helpful in distinguishing that a patient has right ventricular cardiomyopathy. And then lastly is prolonged upstroke of the S wave in V1, V2, V3, greater than 55 milliseconds. So we got an R, an S, and then the upstroke of the S wave. That's what they're calling this thing here. And if the duration of that is greater than 55 milliseconds, then that suggests ARVD. Now Brugada Syndrome, we'll do the first pattern, which would be the classic pattern. And the Brugada Syndrome is a relatively uncommon heart rhythm disorder that can lead to people having sudden death or near syncope or palpitations. It looks like a right bundle branch block and leads V1, V2, and V3. And then you see the J point is elevated 2 millimeters or more. The J point is the junction between the QRS and the ST segment. So in this complex, here's the QRS. It probably ends somewhere around here, and the ST segment begins. So the J point is there. And in this example, it's clearly elevated more than 2 millimeters. And then also the ST segment is coved down. So the ST segment looks more like this than it does this. And I think you'd agree that it's more of a coved down, although it's pretty much diagonal in this example. But it's definitely not coved upward. So that's Brugada Syndrome, pattern 1. Now some pacemaker stuff. This is going to be atrial sensing and biventricular pacing. Biventricular means both ventricles are paced, and that's used for treatment of heart failure and cardiomyopathy in the presence of left bundle branch block or the requirement for right ventricular pacing. Let's look over here at the schematic. So the pacemaker box is sitting under the skin of the chest, and they're typically 3 leads, which is a little confusing because it's biventricular pacing. So you see the bi and you think 2, but they're actually 3 leads usually. There's the lead that goes into the atria. That's the atrial lead. There's a right ventricular lead, and then the left ventricular lead goes into the coronary sinus and then into a lateral coronary vein, and that sits out on the outside of the left ventricle, and that's used to pace the left ventricle. So those are typically the 3 leads that are used for biventricular pacing. And so if you see pacemaker spikes, it's good to look at the morphology of the QRS. I find V1 the most helpful lead to look at. And it looks kind of like a right bundle. It goes up. So if it looks like a right bundle, then that suggests biventricular pacemaking, because a normal right ventricular pacemaker V1 complex will look typically more like this. It'll be negative. So if you see that it's upright in V1, then you're probably dealing with a biventricular pacemaker. Another feature is there are two pacemaker spikes visible here in V3. 1, 2. So that suggests that there are two pacemaker leads going off. And they go off at different times. That's the whole point, because the different parts of the heart need to be paced at different times to make the contraction be synchronized. You won't always see two pacemaker spikes. For example, V5 and V6 only show one pacemaker spike. So that's not required to diagnose biventricular pacemaking. It's more typically what the V1 lead looks like and the clinical scenario. And lastly, this is a atrial sensed rhythm because there's a little P wave visible here before each QRS. So the device is sensing these P waves and then delivering BiV paced complexes after each one. Here's our last item: ventricular pacemaker with failure to sense. This strip is a little confusing because it's got multiple leads. So these morphologies are all changing because the lead's changing throughout the strip. So let's start here for this. We've got a QRS, and then there's a pacemaker spike right afterwards. So that happens in spite of the preceding QRS. That's not normal, because the pacemaker should know it's not supposed to pace since there was just a QRS complex. Here's another QRS complex, and then there's a P wave, and then there is an RV pacemaker spike, and it captures because there's a QRS afterwards. This one over here didn't capture because the ventricles were still refractory and couldn't depolarize. But at this point, the preceding QRS was here, so there was time for the ventricles to become non-refractory, and this pacemaker spike captures. Here's a T wave, P wave, and then we've got another QRS, and there's a pacemaker spike right in the middle of it. So this is abnormal. Again, the pacemaker should sense that the QRS is already underway, and it shouldn't try to pace. Here's another QRS. Then there's a pacemaker spike here, which is hard to see, and that captures. Then we go on to V6. This is just a marker here that you've switched to a new lead V6. That's not a pacemaker spike. So often comes up as a question. So then we got another complex here, and there's a pacemaker spike right here, and then there's a QRS. But this pacemaker spike happens after the QRS is already underway. So this is an inappropriate pacemaker spike. It should be sensing that the QRS is happening and not deliver a spike. And then over here is probably the best example of the whole thing, and that is you've got a QRS, and then here there's a pacemaker spike happening on the T wave in spite of the QRS just happening. So the pacemaker is trying to pace when it shouldn't, and that indicates a failure to sense. So there you go. You just finished level 3 of the world of ECG. I wish you success in all of your clinical and academic endeavors.